Bismillah ar-Rahman ar-Rahim. This session about the interstitial lung disease is very interesting topic. First, thanks Professor Tariq Safwat and all the organizing committee, Professor Ashraf Hatem, Professor Adel Khattab, Professor Ahmed Al-Halafawi, and all the members. Now, it's a pleasure to me to introduce my dear friend, Professor Yusri Aql, talk about diagnostic approach to interstitial lung disease.
Bismillah ar-Rahman ar-Rahim. Thanks, Mr. Chairman, my professors, dear colleague. It is my pleasure to be here today and share this ILD session with our great guest. And my talk will be about how to diagnose a case of interstitial lung disease in the least invasive way. Be very cautious. You are almost always dealing with a very fragile patient at most of the time. I will start with two case scenarios. 63 years old male patient in a smokers complaining of progressive shortness of breath of the used durations, has some autoimmune features, renal phenomena, and arthralgia, and we detect bilateral basal crackles in the absence of other signs of heart failure. And if you see for his HRCT, you can detect this peripheral reticulations. The disease become worse as we go down. You can detect traction bronchiectasis, starting areas of honeycombing. It is more worse in the lower lobe. This is definite craniocaudal gradient and peripheral central gradient, and you can detect that there is a little bit degree of dilated esophagus here. What is the most likely diagnosis? Is it idiopathic UIP IPF? Is it fibrotic HP? Is it fibrotic NSIP? Is it connective tissue disease related UIP? Or it is idiopathic UIP with autoimmune features? Another case, 40 years old male patients with significant SACA manifestations, elevated sedimentation rate, antro and antila positive. She was paired Fanisar, and she's coming with this cystic pathology in the lung. You can count the cyst. If you look to the coronary formatted image, you can count the cyst. What is the most likely diagnosis in such a case? Take care, all the five choice can cause cystic pathology in the lung. Is it DIP? Is it cystic HP? Is it LIP? Is it PLCH? Or it is fibrocystic sarcoidosis? Back to the my talk. When you face a case with ILD, you have to do comprehensive evaluation, which requires the following steps. First is medical history, followed by physical exam. Radiology, it is very essential step in picking up the diagnosis in ILDs. You can do some blood tests. In some cases, you can go for bronchoscopic samples, fiber optic bronchoscopic samples, and in most of the times, it is just PEL. In a few cases, you can get transbronchial lung biopsy, either for sepsis biopsy or cryo biopsy, and in very limited patients, you can go for surgical lung biopsy. After you make up your diagnosis, you have to assess the physiological derangement of your patient to monitor the severity of the disease, the dynamic of the disease, and the response to treatment. I have to address that. IPF stands for idiopathic pulmonary fibrosis, and the IPF should be UIP, but not all UIP are IPF. Okay, IPF is the commonest idiopathic interstitial pneumonia, but not the commonest ILD at all. The commonest ILD in our registry in Egypt is HP, followed by connective tissue disease-related ILD. Sarcoidosis ranked 3. IPF represent 10% from our patients. This is regarding the prognostic classification of ILD. As we go from the left to the right, we are going from inflammatory disease to fibrotic disease. We have good anti-inflammatory drug, but we don't have this fantastic anti-fibrotic drugs. The FDA approved and anti-fibrotic drugs can stabilize the disease course in some forms of chronic progressive fibrosing ILD, but not even in all patients with this disease. You have to start your workup with history, and it's a very important part in the evaluation of your patient is the history. And the history, you have to fulfill all these items: gender, age, smoking history, medication, occupation, environmental exposure, and so on. Regarding the age, there are certain ILD that can develop in certain age group: sarcoidosis, connective tissue disease-related ILD, LAM, PLCH, mostly occur between the age of 20 and 40 years. I can add HAP in Egypt. And in male patients, IPF, it's the age, it's the disease of old age. In the most cases, most of the time, it happens or develops after the age of 60. And one of the theories for the development of UIP-IPF is accelerated aging process in the lung. If you meet a patient who has UIP-IPF in young age group, you have to consider it may be the possibility of being a familial IPF. Familial IPF is the same like a UIP-IPF, the difference only in the age group. Second in the history is the gender. There are some female predominance in certain disease and male predominance in others. LAM is exclusively female disease. Sarcoidosis more common in females. Chronic eosinophilic pneumonia, SLE and scleroderma and their connective tissue related ILDs are more common in females. There is male predominance in PLCH and IPF. But there is some recent literature that stated that the incidence of PLCH is the same in male and female. But in our registry, still PLCH is more predominant in males. Smoking history is very essential because we have a big list of smoking-related ILD, RP, RP-ILD, DIP, SREF, UIP-IPF, or smoking-related ILD. Smoking seems to be protective, but doesn't prevent the development of sarcoidosis and hypersensitivity pneumonitis. It's related to its inhibitory effect in the alveolar macrophage, in the lymphocyte, in the antigen productions. If these diseases develop in the smokers, the course will be more worse than non-smokers. This is a question, but the answer is there. All the following diffuse lung disease are associated with smoking: IPF, RP-ILD, DIP, HCP, histiocytosis X. I think the answer is the red one, which is HP. It is not smoking-related disease. In a disease, in a severe disease, pulmonary renal syndrome, Gutt-Bashar syndrome, 100% of patients who are smokers, they develop alveolar bleeding. Only in 20% of non-smoker patients develop alveolar bleeding, and the main pathology will be in the kidney. Asbestos workers or smokers are likely to develop asbestosis. Asbestosis is essentially UIP. The same is for rheumatoid lung. Rheumatoid lung is more common in smoker, and it is also UIP. Drug-induced lung disease, it is a very big list of drugs. You can insert any name of any drugs that can cause ILD, but the most notorious drugs are methotrexate and amiodarone. Methotrexate is the most potent joint controlling agent in rheumatoid arthritis, but it can cause ILD. But you have to keep in mind that in most of the time, when you face a patient with rheumatoid arthritis and ILD, and he is on long-term methotrexate therapy, the disease is mostly, the ILD I mean, is mostly disease-related and not drug-related. Second is amiodarone. It can cause a big list of diffuse lung diseases. It is one of the most potent anti-arrhythmic drugs. Genetic and familial history, you have now what's called familial IPF. About 5% of UIP-IPF runs in families, and the same for sarcoidosis. About 6-20% of patients have a definite family history. These examples of genetic-related ILD, all of them are rare diseases, in fact. Now, this is the most difficult point in diagnosis of ILD, which is exposure history. Occupational exposure, we can eliminate occupational exposure so easily, but about the environmental exposure. Elimination of exposure history is, to diagnose UIP-IPF is one of the pitfalls of ATSCRS criteria to diagnose IPF actually. You can eliminate occupational exposure, but about environmental exposure, especially in highly polluted settings. This is the at-risk occupations as we see. The symptoms of diffuse parenchymal lung disease are almost the same. We have what's called ILD syndrome. Patient who gets ILD has stiff lung, bad compliance, increasing elastic work of breathing, so he suffers from shortness of breath. And one of the most distressing symptoms in some ILDs is intractable cough. It can happen 24/7, especially in fibrotic HP and IPF, and it is hard to be controlled in a good volume of patients. This is regarding the pulmonary symptoms. You can detect extrapulmonary symptoms mainly in systemic disease. But some ILD, not systemic disease, without systemic disease, have some autoimmune features. We have EPF, idiopathic interstitial pneumonia with autoimmune features. We have HP with autoimmune features. Sarcoidosis, pulmonary sarcoidosis can cause a lot of extrapulmonary manifestations without real affections of the symptomatizing organs. This is a big list of extrapulmonary symptoms. Then comes the physical examination of the patients. The pulmonary, you can detect some findings in the local exam. It adds a little to the diagnostic workup of a case of ILD. But if you hear bipassal crackles in older male patient, ex-smokers, in absence of signs of heart failure, this may point towards the presence of UIP. Also, if you hear high-pitched musical sound with quack, especially in ventral aspect of the lung, this point towards the presence of small airway disease, mostly HP. HP is essentially a small airway disease. In the general exam, you can detect a lot of signs, especially if the ILD is connective tissue related, which is related to systemic disease. But you can detect the presence of finger clubbing. Clubbing can happen in any interstitial lung disease. HP can cause clubbing, sarcoidosis can cause clubbing, but it's more common with UIP, IPF. 25 to 50% of UIP, IPF patients have clubbing. Clubbing has prognostic rather than a diagnostic significance. If you have two patients with the same pathology, with the same degree of physiological derangement, one with clubbing, other one without clubbing, the one with clubbing will do more worse than the other one. This is then when it comes to workup, you can ask for some lab tests, physiological assessment, the last step, and the most essential step is the radiographic examination of the chest. You can get some lung samples, PAL or transbronchial lung biopsy, and in few cases you can go for surgical lung biopsy. Lab test common that in the top of the list is connective tissue panel, what's called the collagen profile. But the question is, should you do connective tissue panel in any ILD patient? The answer is big no. You do this only in one case. If the ILD, which is present in the lung, is fitting with the interstitial pneumonia that can happen in the course of connective tissue disease. I mean, if you see NSIP, NSIP is commonly connective tissue disease related. Idiopathic NSIP is rare. OP, NSIP, OP overlap, LEB, mosaicism related to small airway disease, UIP. In such a case, you have to do connective tissue disease panel. Also, you can check serum immunoglobulins in some patients, like patients with CVID and patients coming with GLILD or patients with chronic granulomatous disease. You have to check their phagocytic functions in the lung. The phagocytic functions of their neutrophils. This is a big list of autoantibodies that can you do in the course of connective tissue disease if the morphological domain of the ILD is fitting with one of the interstitial pneumonia that can happen with connective tissue disease. The role of the physiology is mainly prognostic. You assess the degree of disability, you assess the severity of the disease, you monitor the dynamic of the disease, the response to treatment. It is a restrictive syndrome at most of the time, pure restrictions. You have to do spirometry, lung volume, diffusion. It is pure restrictive disease in most of the cases with impaired gas transfer. And the lung volumes drop in parallel. You get reduction in lung volumes and also in the gas transfer. If you see a patient with ILD who has marked reduction of the diffusion. Out of the reductions in the lung volumes, you have to think about concomitant vascular pathology in the lung, like what happens in patients with scleroderma-related interstitial lung disease. In some cases, in some diseases that has bronchocentricity, like sarcoidosis, like HP, like PLCH, you can, like xenophilic pneumonia, you can get both restrictive and obstructive pathology in the lung. Even a patient with PLCH, you have to follow the course of the disease with the FEV1 and not with the FEPC. And if you find significant decline over 6 months in the FEV1, whereas the patient on high dose methotrexate and steroids, you have to shift it to the other line of therapy. I mean chemotherapy, and either cladribine or BRAF inhibitors, depending upon the cytogenetics of the tissue sample. Very essential is to do dynamic study. 6-minute walk test is sample test and is very informative. You detect the degree of the oxygen desaturation during the test, the distance cover initially and with follow-up. If you have a patient who has significant reduction in the oxygen desaturation during the test, think about fibrotic HCP. Then it is a role of the radiology, and it is very important. The plain X-ray is of little significance actually. It has limited role in diagnostic workup of diffuse lung disease. The X-ray may be completely normal and the patient has diffuse lung disease in contrast, but you can detect some reticulation pulling up or pulling down of the hilar, reduction in the lung volumes depending upon the site of the fibrosis and the extent of the fibrosis. The most important diagnostic modality in diffuse lung disease, the diagnostic modality that changes totally the face of ILD is good quality HRCT. I will repeat again, good quality HRCT. But HRCT has some pitfalls. The most important one, the good quality exam is not always present. More than 80% of patients who referred to our unit come with substandard exam, and we repeat the exam at our institute because we have a very good HRCT protocol. The second pitfall is we have about 300 diffuse parenchymal lung disease. In contrast, we have a few radiological patterns. This reflects the limited capacity of the lung to deal with injury. Actually, the patterns of HRCT reflect what is going on at histo. The third pitfall that's called gravitational ground glass or dependent atelectasis. So in the initial workup, initial assessment of a case with ILD, you have to do entire inspiratory exam, incremental expiratory exam for air trapping, and the incremental pro exam to avoid this dependent atelectasis or the gravitational ground glass. The last pitfall is that we are still using a term called the ground glass lung. This is a big pitfall in the HRCT. In the past, ground glass means a good prognosis, means an inflammatory disease, increase the degree of immune suppression, the patient will improve. This is actually not true. The list of differential diagnosis of a ground glass lung is very long list, starting from inflammatory pathology, partial filling, to ugly fibrosis. We'll take some example. All the cases are from our registry. Is a 25 years old male patient, heavy smoker, sound plaster. He joined this job from a few years, coming with progressive shortness of breath of few months duration, and this HRCT finding, as you see, diffuse central nodular pattern with clear lymphatic surface of the lung and some on the posterior segment of the right upper lobe. And if you look at the mediastinal window, you can detect the presence of calcified mediastinal lymphadenopathy. This together with the clinical history of the patient fit with accelerated silicosis or acute silicosis. This is another patient, 12 years old boy, referred to our unit with a diagnosed hypersensitivity pneumonitis and he is on immune suppression. If you look at the HRCT, you will detect mega dilatations of the major pulmonary artery, of the main trunk of the pulmonary artery. And this patient was found at right heart case to have a mean pulmonary artery pressure of 55 millimeter of mercury. He has severe degree of pulmonary hypertension. He has centropial nodular pattern, but if you look at the centropial patterns, they are to some extent patchy, they are bizarre in attenuation, some are ground glass nodules, some are soft tissue attenuated nodules that are not evenly spaced within the lung. They don't affect the entire cross-section, axial distribution, no any signs of air trapping. So I was not convinced with the diagnosis of HP, and I asked for surgical lung biopsy, VATS biopsy. Transbronchial lung biopsy in this patient is very serious. It is very dangerous. It can end the life of the patient because of the severe degree of pulmonary hypertension that he has. The biopsy result revealed the presence of diffuse pulmonary capillary hemangiomatosis, which is a rare interstitial lung disease and a rare cause for pulmonary hypertension. So immune suppression has nothing to do, and the treatment should be lung transplant. This is 42 years old female patient per definition, progressive shortness of breath over months and years. They show this diffuse nodular pattern, diffuse centropial nodular patterns. All the nodules are fuzzy, are of ground glass attenuation, and they are evenly spaced within the lung, and affecting the entire cross-section of the lung in the axial distribution, as you see, is very typical for hypersensitivity pneumonitis together in the, with the clinical history of the patient. This is another centropial pattern. You can detect soft tissue attenuated centropial nodules. Some show tree-impad. Tree-impad means the presence of bacterial secretions in the terminal airways. And if you look carefully to the section, you can detect the presence of bronchiectasis at the level of the large airways. So this patient has bronchiectasis and impacted secretions in the terminal airways that cause this centropial nodular pattern. This is another nodular pattern which is different from these examples. The nodules are soft tissue attenuated micronodules affecting only the lymphatic surface of the lung. You can detect some subpleural nodules, nodules within the interlobular septa, nodules along the axial interstitium. They are patchy in distribution. It's typical for perilymphatic nodules. At most of cases, more than 95% of patients presenting with perilymphatic nodules are sarcoid patients. The other causes are very rare. Silicosis, you can eliminate silicosis in a chronic phase. You can eliminate it from the history, absence of exposure. Lip can occur within the with connective tissue disease or immune deficiency disease. The clinical presentation of the patient will be totally different, and it can occur as in lymphangitic spread of cancer. But keep in mind that the lymphangitis carcinomatosa is essentially reticular pathology, and I will show one example right now. This 25 years old male patient, high fever, toxemic manifestation, is presenting with this micronodular pattern of soft tissue attenuated, affecting also the lymphatic surface, a lot of subpleural nodules, a lot of lobules within the interlobular septa, lobules along the axial interstitium. But if you move your eye from the mediastinum of the chest wall, you can pick up nodules anywhere within the lung. So it is called random pattern, and this random pattern means it's the lymphohematogenous spread of disease, mostly infection. Most of the time it's TB, but viral infection, fungal infection can cause the same pictures, but this is rare, and also lymphohematogenous spread of malignancy can cause the same. I will show these 4 cases, all presented with what's called the mosaic lung. The clinical scenario is very important. Please don't interpret the image in a vacuum. Don't interpret the image in separation or isolation from the clinical history of the patient. You have to interpret each RCT finding within the clinical context of your patients. The first one is, the first one is one on the left is 45 years old per definition patient presenting with long-standing history of progressive shortness of breath, marked oxygen saturation with exertion. If you look at the section, you'll find that the section affects the entire cross-section of the lung. You have areas of ground glass attenuation. You have lobular air trapping in different sites, and you have lobar air trapping. The entire middle lobe and the lower lobe are air trapped Also, most of the lower right lower lobe show air trapping, and you can detect some cystis, some true cystic pathology in this case. This is a case of hypersensitivity pneumonitis. Look at these two examples. Both of them show sharply demarcated mosaic lung. Sharply demarcated mosaic lung. The first example is not sharply demarcated. This sharply demarcated mosaic lung. Sharply demarcated mosaic parenchyma means one of two things. Either you are dealing with small airway disease in most of the cases, or pulmonary vascular disease in a minority of patients. Again, back to the history of the patient. The first one is 25 years old SLE patient with antiphospholipid antibody positive, presenting with a few days history of shortness of breath. So this mosaic lung is most related to a pulmonary vascular event, PE, and we detect big blood clots in the pulmonary arteries at angio. In contrast, this 40 years old female patient, she presents with long-standing history of shortness of breath, years without dyspnea, without adventitial sounds in the chest, and you can detect the presence of this sharply mutated mosaicism. This fits nicely with small airway disease. The clinical scenario is totally different. Lately, this patient developed SECA manifestation and anti-lab positive, so it is a case of Sjogren syndrome with constricted bronchiolitis or fibrotic bronchiolitis. It's a 42 years old, the last case is 40 years old female patient, Bird Fanisser, exertion shortness breath. It can fit nicely with HP. But again, it's a clinical history. The main complaint of this patient was recurrent attack of life-threatening hemoptysis that necessitated blood transfusion several times. This symptom can't happen with hypersensitivity pneumonitis. So we got transbronchial lung biopsy from this patient, and the diagnosis was idiopathic pulmonary hemosiderosis. These 4 examples of mosaicism. The clinical history is very essential to make up the diagnosis correctly. The 65 years, we'll move to another pattern. The 65 years old female patient, diabetic hypertensive ischemic, presented with recent acceleration of his level of dyspnea. And if you look carefully at this T, you will detect diffuse reticular pattern, a smooth interlobular septal thickening, a smooth rim of bilateral effusion, dilated heart, very characteristic for heart failure. In contrast to this one, this diffuse reticular pattern, some of the reticulations are the septal thickening is smooth, others are beaded, and you can detect some nodulations on the lymphatic surface of the lung, I mean over the pleura. This is a case of sarcoidosis causing this histological probe in case of sarcoidosis, because this smooth reticular pattern, but you have beaded reticular pattern in other sites. This 28 years female patient coming with a short history of severe shortness of breath. Her chest was completely clear, no signs of heart failure, and the pattern that we see is diffuse septal thickening. You can figure out the secondary pulmonary bule, the secondary pulmonary bule, and the central arteriole. All the interlobular septa are thickened in this way, smoothly thickened. You can detect some alveolar ooze, you can detect some nodulation. This is a classic HRCT finding of lymphangitis carcinomatosa. Again, lymphangitis carcinomatosa is not a nodular pathology at Paris. It is essentially reticular pathology rather than nodular pathology. It's a case of advanced pleuroparenchymal fibroelastosis. Pleuroparenchymal fibroelastosis represents about 60% of our registry. This 36 years old female patient known to have scleroderma. And this is here HRCT, you can detect ground glass opacifications affecting the peripheral aspect of the lung, gets more worse in the lower lobe, and you can detect nicely the presence of subpleural sparing sign. The immediate subpleural lung is to some extent healthy. This is a very characteristic sign for NSIP. This in contrast to this diffuse reticular pathology, peripheral reticulation, definite central to peripheral gradient. This is more in the lower lobe, retraction bronchiectasis, honeycombing. This is UIP, IPF. Again, these 2 different patients with cystic pathology. The one on the left is the one, the first patient that I present for. She has antral positive SECA manifestation, and the cyst is a coronal image, you can count them. This is very classic for cystic lip. In contrast to this 25 years old heavy smoker male patient who present with exertional shortness, suppressed recurrent attacks of pneumothorax, and this massive cystic pathology in the lung. The cysts are bizarre in shade, bizarre in different size, and this is very characteristic for BLCH. And you can notice that it's relative sparing of the tips of the lingula and middle lobe. This is some example of the hyper-attenuated pattern is one of our cases. Is a young male presenting with 6 weeks history of fever, received a lot of courses of antibiotics, and these consolidated patches of the lung. If you look at the distribution of the patches, you can detect that the patches are distributed along the axial interstitium, and most important along the perilobular areas. This perilobular area of consolidation, what's called the perilobular sign, which is very unique for organizing pneumonia, especially cryptogenic organizing pneumonia. This is another example of a patient long-standing history of bad asthma, excessive expectoration, and this has massively dilated airway with this hyper-attenuated material inside the airway, which is pathognomonic for allergic aspergillosis. This is a classic case of sarcoidosis, 45 male patients with arthralgia, erythema nodosum, low fever, and this discrete mediastinal lymphadenopathy, very characteristic for sarcoidosis. In contrast to this female, this 30 years old female patient has long-standing history of autoimmune disease. She reported the presence of autoimmune hemolytic anemia while she was in her secondary school. Few years later, idiopathic thrombocytopenic purpura, ITP. She was in long-term steroids for a long period. She was presented to me with extensive cervical lymphadenopathy, high fever, a huge splenomegaly. Also, she reported the presence of recurrent bad attacks of the sinusitis. I got lymph node biopsy from the cervical gland, and the histopathology report was this is non-caseating granuloma fitting with sarcoidosis. At that moment, you have to stop for a while, take a deep breath, make up your mind. What about the long-standing history of autoimmune diseases? What about the autoimmune hemolytic anemia, the recurrent attack of bad sinusitis that she has? Should I check her serum immunoglobulin for the possibility of being CVID? And what is present right now in the lung is GLILD? This is what I did. I checked here serum immunoglobulins, and all the serum immunoglobulins were found to be very low. So this is the case of CVID, and what's present in the lung is GLILD. So the first line therapy is optimization of here serum immunoglobulins by replacement therapy, and you can add any immune suppression. Most likely, most important is anti-CD20 rituximab to control here ILD. In some cases, you can go for bronchoscope and bronchoalveolar lavage, and the lavage in itself may be diagnostic, even in its gross appearances. The milk lavage of alveolar bittinosis, this is the hemorrhagic lavage, the increasing bloody lavage in alveolar hemorrhage diseases. The TLC and differential cell count of the lavage is very important, and you can make the diagnosis together with the clinical and radiological context of your patient in a big volume of patients without going to invasive lung biopsy. Lymphocytic lavage, you can take NTP, sarcoid, but the most important disease is called significant lymphocytosis in the lavage. The lymphocyte may reach up to 80% is hypersensitivity pneumonitis and non-fibrotic phase. And if you go for flow cytometry, you will detect that more than 80% of T lymphocytes in HP will be of CD8 subclass. In contrast, sarcoidosis with CD8, CD4, CD8 ratio will be so high, more than 4. The cytology may be diagnostic and the pathognomonic. Also, if you can diagnose BLCH in its nodular phase or in fibronodular phase by detection of CD1A positive cells if they are more than 5% in the bronchoalveolar lavage. You can go for transbronchial lung biopsy in limited number of cases, and the transbronchial lung biopsy, either forceps biopsy or cry biopsy, is diagnostic especially in patients with bronchocentric disease like sarcoidosis, like HCP, like LAM, like PLCH, Also, it is of value in eosinophilic pneumonia, lymphangitis, spiridium carcinomatosa, diffuse alveolar damage, alveolar epitenosis, and so on. In small volume of patients, you can go for surgical lung biopsy, but be so careful, be cautious. You are dealing with very fragile patient. Then to go for surgical lung biopsy, it's better to bypass unless you are not able to pick up or to make a correct diagnosis based upon the clinical, radiological context of your patient and the bronchoscopic sample. In the near past, the surgical lung biopsy was considered a gold standard. Right now, there is no gold standard in diffuse parenchymal lung disease. It is clinical, pathological, radiological correlation. And if we are to nominate a gold standard for ILD diagnosis, it should be your clinical acumen. Thank you so much.
Thanks, Professor Dr. Yusri. First, I'd like to thank all the organizing committee for this great event. And it's time to introduce Professor Bertram Robrecht to present treatment options interstitial lung diseases.
Thank you very much for inviting me to come here. It's a great pleasure to come here to Cairo. It's the first time in my life to be here in Egypt and in Cairo, and to speak to here about the topic of the ILD treatment. I will focus in my speech on the fibrosic type of ILDs. There's not enough time to cover all ILD. I come from Germany, here from Bielefeld, it's a town in northwest Germany. Here you see the town and our hospital there. These are my disclosures. And what I want to focus is that some things I will mention here in my speech are treatments which are probably still off-label here, and so they must be considered very well in use. Speaking of fibrosing lung diseases and their therapy is first of all speaking about IPF treatment. IPF, what we have learned already, is a disease with a very poor prognosis, poorer than most cancer diseases. Ironically, just lung cancer has a worse prognosis. The median survival before the era of treatment is under 5 years, which is very poor. And we don't know what kind of patient we have in front of us. Is it a patient who has a very rapid progressive disease, line A, or one with a less progressive disease, with a longer course of disease, or is it one, what we see very often, who has some periods of relative stable disease, and then again has a sharp decline in case of exacerbation of his disease, and then again perhaps a moderate decline, and then he dies of another exacerbation. That's what we see most often. What kind of treatment options have we got for these patients? First of all, there's a medical treatment, and that's the main focus of my speech. We have got 2 new drugs during the last years which are quite effective there. But we have to keep in mind that medical treatment is not everything. We need a lot of supportive care and non-pharmacologic measures for these patients, starting with oxygen therapy, with treatment of infections, vaccination, rehabilitation medicine, and so on. We have to focus also on the treatment of exacerbations, because they are the things that are very dangerous for these patients. But everything we do in exacerbations, and we do a lot to keep these patients alive, it's not yet proven to be effective. And we have to treat comorbidities of this patient. These patients are old, they have a lot of comorbidities going along with their fibrosis disease, and we have to keep them in mind. And only a very few of our patients qualify for lung transplantation because they are very sick, they have very many comorbidities, and they are too old to be good candidates for lung transplantation. And if we look at our guidelines, there's many things, many against treatment, what we should not do. Until 2012, we thought that the combination of prednisolone, azathioprine, and acetylcysteine would be a good thing. Now we know now that we harm these patients with this therapy, and they live shorter. And all these other therapies, they didn't show really a good effect in those patients with pulmonary fibrosis. What is left? There's two antifibrotic drugs, nintedanib and pirfenidone, and they're also in the 2015 guidelines appears antacid therapy. I guess if we have an update of this guideline 2019, the antacid therapy would be no more with the conditional yes, but perhaps with a conditional no. In patients who don't have a reflex therapy, it's shown in the recent years that they have got perhaps even worse on the antacid therapy, that they do have more infections. So many things are changing. Looking at the two drugs we have. First is the pirfenidone. Pirfenidone was approved in 2014, and we do not really know how it works, but we have hints what kind of mechanism it acts. It is an antifibrotic action on the TGF-beta pathway, and the inflammatory action with the TNF-alpha, and probably an antioxidant action. The other one, the nintedanib, is a triple kinase inhibitor. It's not only a drug for pulmonary fibrosis, but also and very much for cancer, because it has an anti-angiogenic, anti-tumor activity. It's approved for non-small cell lung cancer, and it's in study for many other kinds of cancer and used there. And the main effect is in fibrosis is the effect of the kinases on the antifibrotic and anti-inflammatory. And we see in the studies that it works. Pirfenidone works, and it's really astonishing how good it works. It reduced within 1 year the risk of a sharp decline in the forced vital capacity, or in cases of death, about half. About half the patients had this big benefit. And it has a big benefit also in the increase of progression-free survival. Patients on pirfenidone survive longer without progression. And these data from the trials for the approval are also true in the registries who look for the patients for a long time. Here in this Belgian registry, we looked at patients for 2 years, and there was virtually no real decline in lung function in them. So it really works also in real world data. The second substance, nintedanib, has about the same effect, about 50% reduction in the decline of the vital capacity in 1 year in both the Impulses 1 and Impulses 2 study. It has also a good effect on exacerbation, but it did not reach level of significance. You see here the level is just a bit above, but the trend is very good, what you see here. What about mortality of these two drugs? we see in pirfenidone, we have a significant reduction of IPF-related mortality. We have a reduction in all-cause mortality, which is not as good, but it is there, and in the meta-analysis it's also significant. So, what about mortality in nintedanib? The studies that we have here show that there is reduction in mortality, but it does not reach level of significance. There's a good trend, but neither in all-cause mortality nor in mortality due to respiratory causes it's reached significance. But there's a good trend. Side effects. And the side effects of the two treatments are what restricted the therapy to many patients, because they are often and they're quite threatening for the patients. For pirfenidone, we know all the dermatologic side effects, the rash and photosensitivity, but that's not all. Those patients also have gastrointestinal side effects. Anorexia, nausea, dyspepsia are quite common, and even diarrhea appears in these patients. But this gastrointestinal side effects are the most common side effects we see in patients with nintedanib. In a very big percentage of them, they have diarrhea, which is real threatening for them, and which leads to end of therapy, not only in a few cases. And as nintedanib is an anti-angiogenic substance, we have also bleeding events there that we have to keep in mind. The diarrhea is the most severe and most common side effect of the nintedanib. We have a good protocol from the study, which can be used also in everyday use of these medications, how to handle with these diarrheas. And some of the patients you can reintroduce again the nintedanib with effective and good control of the diarrhea, but in others it must be discontinued, permanently discontinued. Looking at the patients who are on therapy is very important, and these data from a French registry I found in this year's ERS Congress very interesting, how the patients see the therapy and how we as physicians see the therapy on them. Most patients see a positive effect, no doubt, 80%. But quality of life, only half of the patients see a positive effect. And that's what we found in all the studies, that positive effects of quality of life are not significantly found. Another thing, what I found interesting is that our patients are fighters. We think as doctors that about 1/3 of the patients have resigned, are discouraged with the disease. Fact is, more than 85% are not resigned. They are determined to fight the disease, and they accept the side effects, the strong side effects of the therapy, to have a longer life, and only a few don't accept the side effects for them. And another thing, what we underestimate is that the patients want to be involved in the decision for their treatment. We think they want to delegate it to us. That's not true. 80% want to be involved in the decision. And what do the patients experience? They experience, the adverse events are not so common as they thought, most of them. And they see, even though the benefits are not greater than they expected, that the benefits are better than the disadvantages for them. And another thing, last thing from this registry data, patients wanted to be treated earlier. They regret that they haven't offered this therapy earlier. They have the hope that if they have treated earlier, then they would be in a better state. We have to keep that in mind. It's an expensive therapy. but the earlier we start, the better the effect is. Coming to the next type of interstitial lung disease, which goes along with fibrosis. This is systemic sclerosis. Most patients with systemic sclerosis develop an interstitial lung disease to any proportion, some more, some less. And the interstitial lung disease in these patients is the main cause of death in them. About 1/3 of the deaths according to systemic sclerosis is associated with interstitial lung disease. The second most often is the pulmonary hypertension, another pulmonary disease. And the pulmonary involvement in these patients is that what is the main factor associated for the reduction in survival. Systemic sclerosis, a disease not only affecting the skin and, as I said, the lung, but all different kinds of organ systems, the heart, the gastrointestinal tract, the kidneys, the musculoskeletal system, a real systemic disorder. What can we do for this disease? We can do for the lung disease in systemic sclerosis what we can do for the systemic sclerosis itself. We can use immunosuppressive drugs like mycophenolate, up to biologicals. Some patients who qualify for autologous hematopoietic stem cell transplantation. A very big and important role plays the supportive care with oxygen and other measurements, and only a few of these patients qualify for lung transplantation as a kind of cure of the lung involvement. As we don't looking at the fibrosis, at the key point of this disease in the lung, research was done on antifibrotic agents, and the hope it does not only work in the lung, but also on the other side, where fibrosis appears in the skin, for example. And it's not surprising that the two substances used for pulmonary fibrosis are also researched in the sclerosis associated with systemic sclerosis, pirfenidone, and the TKIs. First substance, the nintedanib, was studied in patients who had a substantial involvement of the lung, who had a substantial decline in their normal lung function, and diffusion capacity, and was looked at how does the nintedanib works on the decline of the forced vital capacity in these patients, and if there's any effect on the sclerosis on the skin side, and what does happen with the quality of life in these patients. This study was published this year, well before the American Thoracic Society Congress in May. And what does it show? First, the patient here, they were allowed to continue their immunosuppressive therapy with prednisolone and mycophenolate or methotrexate, and if they deteriorate, they could be got therapy with other patients with this disease also. And what we see is the rate of reduction of decrease of vital capacity was about the same we saw in other patients with fibrosing lung disease. Surprise. About 40 to 50%. And here you have the comparison in the census study for the patients with the systemic sclerosis compared with the impulses for the IPF. About the same rate of reduction of decrease in lung function. And this was independent of if these patients were on an immune suppressive therapy with mycophenolate or if they were not. Both groups of patients did have a benefit of the therapy, showing that probably not the immunosuppressive therapy, but the antifibrotic therapy is what was having the action in them. And life quality wasn't better in them, as we know from IPF, and the side effects of the therapy were about the same we expected also from the IPF data. In summary, we have a good effect, the same effect we have in other fibrosing lung disease, especially IPF, irrespectively what kind of systemic sclerosis patients we have, what at the baseline, they all have the same kind of effect. What we did not have is an effect on the skin. What we hoped we would have, there wasn't any success in that, and there was no effect on quality of life. Few months later, just ahead of the European Respiratory Society Congress, end of September, this article appeared again in the New England Journal of Medicine. Nintedanib in progressive fibrosing interstitial lung disease. What does it mean? Not only in IPF, not only in systemic sclerosis, but in many of interstitial lung disease, we have a phenotype which is characterized by progressive fibrosis with decline in the lung function, worsening of the respiratory symptoms, deterioration, and early mortality. Many kinds of interstitial lung disease have the potential to have this progressive fibrosing phenotype, especially in hypersensitivity pneumonitis, in idiopathic non-specific interstitial pneumonia, but also in all kinds of autoimmune ILDs, not only in systemic sclerosis associated, especially also in the interstitial pneumonia with autoimmune futures, and in exposure ILDs, we have this fibrotic subtype with a poor prognosis. It appears in about 20 to 40% of the patients which have these who have this disease, who have this fibrosing subtype. And the inbuilt trial looked at them, looking at patients who have a substantial grade of fibrosis and a substantial decrease in their lung function, or worsened with the respiratory system, or have an increased extent of fibrosis on their CT scan. And in the study, we had all kind of groups: autoimmune ILDs, hypersensitive pneumonitis, NSIP, unclassifiable, and other kinds of ILDs who were looked at. And what did we see? Again, the same results we saw in IPF, the same results we saw in systemic sclerosis, a reduction in decline of the vital capacity of about 50%. And this was irrespective. If we had an UIP pattern, which normally has a worse prognosis, or if we have another kind of pattern of pulmonary fibrosis, the reduction in decline was over 50%. The adverse effects were about the same, with one exception. We had more patients who had an increase in their liver enzymes. We don't know why we see this in these patients, and there still has to be looked at why this is the case. So, nintedanib works also in other kinds of fibrosing lung diseases which go along with fibrosis, and it works. And it works if they have a UAP pattern or not a UAP pattern on the CT scan. It does not work on the quality of life data, but it looks like that in these patients that they have a reduced risk for exacerbations also, and for death. And the adverse events, except for the increase of liver enzymes, is the same as in other patients with pulmonary fibrosis treated with nintedanib. Well, the other company, Roche, which produced pirfenidone, didn't sleep. They also tested it on patients with non-IPF lung fibrosis, and they saw the same effect. Also, they are not as far in their studies as is the case with nintedanib. But what we will see is that we got probably the same effect on all kinds of fibrosing lung diseases with both of the antifibrotic drugs. What comes in the future? There are many things in the pipeline. Here are just those where trials in phase 3 are enrolling: treprostinil, stem cells, antibiotics, antipulmonary hypertension drugs, and even drugs for normal hypertension, and combinations of those fibrotics or one fibrotic and other substances are on the way. It's interesting what will come. And what's striking for me is we have here the case. We have a disease, not one disease, but many diseases, totally different origin. They have just one thing in common. They have the progressive fibrosis as a common factor of the disease, and one drug, or two drugs, is helping in all of them to reduce remarkably the loss of lung function. It's a total different way we see in, for example, in our cancer patients, where we split to different immunophenotypes and give different therapies to them to get better effects. Here we have one therapy for many diseases with the same phenotype. Thank you very much. That's what I wanted.
Thank you, Mr. Bertram Robrich, right? Thank you for this excellent presentation. And any questions about recent treatment of interstitial lung disease? Okay. Thank you. Now close this session and may go to the coffee break.